Have a good day. This is Professor Yamini Bhushan Tripathi, uh, former Dean, Faculty of Ayurveda, Institute of Medical Sciences, Banaras Hind University. And I have been the Professor of Biochemistry in Department of Medicinal Chemistry. And out of my passion, I have taken this job to understand and to bring awareness about palliative care. I think by now all of you have understood what is palliative care and how it is if implemented in the society by the healthcare providers, by the family members. There are many salient features of palliative care which you might have learned by now. In this class, I am going to talk about the method of interaction of a caregiver with the patient. I have already discussed with all of you about the patient listening. You should be a very good listener. If you are not a patient listener, you cannot appreciate the feeling of your patient. And if you cannot appreciate his feeling, you cannot do what he requires. So the total purpose of palliative care will be defeated if the patient is not happy, because the goal of palliative care is to make the patient happy, make the patient satisfied. His dignity should be maintained, his privacy should be maintained. That is the main goal of palliative care. How you will do it, that is the important thing which I am going to talk to you today. So the title is the interaction method for evaluating an elderly patient with heart failure for palliative care. I have taken an example. You know, there are all the chronic diseases, patients, when disease is not treatable, patient has to live with the disease, that deteriorates his quality of life. So heart failure is one of them. I've taken that example, but the rest of the things are the same. In this lecture, I will also introduce you about the heart attack, about the complications of the heart disease, how the patient feels when he gets post-heart attack in old age. These things I will discuss in this lecture. So now I am going to discuss the interaction method for evaluating an elderly patient with heart failure for palliative care. The objective of this class is to assess and interact compassionately and effectively with the elderly patient suffering from heart failure for palliative care planning. As a patient caregiver, palliative caregiver, your responsibility is to assess the patient condition, mental and physical both, and then you have to decide what kind of palliative care has to be given to him. What do you think is most important when interacting with the patient? Empathy, medical fact, and family dynamics. All the three things are important. Define in palliative care context. Empathy, the ability to understand the patient emotional and physical experience. Medical fact, clear explanation of diagnosis, prognosis, and treatment options. Diagnosis means what is the disease. Prognosis means what is the improvement after the treatment. If the treatment is going on, how the patient is improving. And what are the other treatment options? One is already going on, and what more can be given, what more can be opted. And communication, the ongoing, compassionate dialogue that respect the patient's value. This is very important. This is the responsibility of a caregiver, palliative caregiver. So as a student, you have to learn this compassionate dialogue and respect for the patient value. And then central goal, as I told you earlier, comfort prioritization. The patient should feel comfort, number one. Number two, independence. If he is dependent to his family members, to his fellow members, to his society, some independence should come after your care. How you are going to do, you have to decide. And then is the favorite of the patient. What are the favorites of the patient? For listening music, for eating something, for watching something. All the five sense organs are there. Everybody has a desire of the sense organs. So those sense organs desire has to be fulfilled because the patient is in the end stage of his life and he can't do things by himself. So as a caregiver, what is possible within the limits, what is good for his health, you have to adjust. You have to provide these things. And then autonomy, supporting the patient's right to decide about their care. Most of the time, the family members feel that he should be treated in the best hospital, but it is very expensive. And all of us know that the outcome is not going to be very effective. You are taking a patient, you are lifting by aeroplane, taking to big hospital. But the prognosis of the case is not good at the moment. It may not be better at the moment. A physician decides it, whether it is going to be survived or not. But even then, the family members are very eager to give the best treatment possible. They don't want to leave any stone unturned that, look, my relative, my father, my mother, my patient has not been given full attention. You have to decide the support of the patient's rights. What is the feeling of the patient about his disease? What is the feeling of the patient about his life? It should also be considered. Suppose you want to put a patient on the ICU, on the ventilator, and the patient doesn't want to go on ventilator. You have to discuss with the family members. You have to discuss what is the autonomy of the patient. That is very important. And ultimately, respect in belief, traditions, and practices that shape the patient's health care, expectation, and decisions. I mean, every religion has different kind of belief, different kind of traditions. Depending on that, one has to, cultural aspect of the patient has to be taken care by you. I mean, you can't decide something which is not in practice in his religion or it is in his culture. Don't provide that kind of care, that kind of service. It may be good for him, but since it is not accepted in his family, in his tradition, in his religion, try to avoid it. So compassionate care means medical skill, emotional intelligence, and respect for life's value. Three things are very important. Now, I am giving you example. A patient of 78-year-old stays in bed, chair, more than 50% of the day and needs help for bathing and dressing. Likely scale of his activity is 3. The implication is the focus on comfort, symptoms, relief, and possibly home care or hospital. This is the implication. So now, how to talk to elderly? There are different methods, standard methods, but I have taken one. I am giving you one example. What are the factors? Greet warmly and respectfully. Use title, Mr., Mrs., Doctor, whatever you want, unless invited otherwise. Smile and make eye contact. If you are entering to the room of the patient, make eye contact with him. Very humbly greet him. Speak clearly and slowly. Use simple language. Don't use jargons and give time to respond. Because the patient is in the old age, he will speak very slowly and you have to listen to him. You have to give time to listen. Okay? You cannot be in hurry. And slow, genuine interest. Ask open-ended question about how they are feeling, listening without rushing their feeling. And then be mindful of hearing and seeing. When you are talking to him, you should be fully concentrated to him. Be mindful listener. Sit at eye level. Contact eye to eye should be there. Face them directly and ensure they can hear, see you well. If the patient and caregiver is not emotionally connected, the things will not come out. The actual fact will not come out. You have to be very careful. Then acknowledge the emotions. This is another aspect. Reflect and validate feelings. That sounds difficult, but you have to practice it. The moment you will become a good healthcare provider, you will learn how to reflect and validate the feeling of your patient. And then involve them in decision. Encourage autonomy and explain the choices patiently. Now, the patient is already on the treatment and he is not getting cured by that treatment, and you have gone to his house to give the palliative care. You have listened him, now you have to give options. What are the options? What are the implications of those options? How it will help him? You have to convince him. So respect involve them in decision. Before giving, everybody should agree to your decision. Then only you can start palliative care. Otherwise, how can you do it? And then be sensitive to belief, as I told you earlier, traditions and life experiences. And be patient and reassuring. Avoid interrupting. Offer comfort with words and gesture. With these things, this is a method, HEART, heart method of interaction with the patient. Heart method means HEART. H means hear the patient. E means empathize, acknowledge the feelings, no false reassurance. Assess symptoms means breathlessness, fatigue, sleep disturbance, edema, appetite. These are the common features which a patient, elderly patient with chronic disease have these kind of symptoms. So we have to ask him and we have to scale them, how much they have breathlessness, how much fatigue they feel. There is a questionnaire, I will come later. Then reflect, summarize what you heard, build a report. Means if you have listened the patient carefully, mindfully, then you can summarize. Reflect means whatever you have heard, you summarize them. Then he will feel, look, I have told my caregiver and he have understood my problem. Then he will respect your work. And then talk about goals of the care. And finally, you gently introduce quality of life goal. You have to convince the patient, okay, I have come here to improve your quality of life. If he agrees, then things will be in the right direction. The spike protocol for first interaction. This is another way. This is, I told, this is the heart method, HEART, and this is the spike method. Spike means S means setting, P means perception, I means invitation, K means knowledge, E means empathy, and S means strategy. What does it mean? Create a private, quiet, and comfortable environment when you are going to talk, sitting. Perception means assess what the patient and family already understands. Okay? Invitation, ask how much detail the patient wants to know. Don't give him all this medical knowledge. He is not interested. He is interested in his comfort. He is interested in symptom management. So this invitation. And then knowledge. Share the medical facts clearly and honestly. Don't give him false impression that I am going to treat you, I am going to cure you. You know that things are not going to happen. So don't give any false impression. Okay? Share the medical facts clearly and honestly. Very important. Empathy. Acknowledge emotions and respond compassionately. The patient will say something, respect it, and lastly, discuss next step and support. The question, how can you, is this good time and place to talk? Ensure to no interruption, sit down, establish. Can you tell me what you know about your condition so far? Would you like me to go over all the details and just main points? You ask him, do you want me to go all detail, or I can go only the important points of your medical record? I am afraid I have some difficult news. Use clear, simple language, avoid jargons. Because why this is important? Because you know that the patient has expectation that he will be cured, but you know that he is not going to be cured. But then you have to say in a very passive manner, not active. Oh, no, you are not going to be cured. You have to tell this fact in an indirect manner, in a very compassionate method. This is very important. Art. You know, many things can improve if psychologically a patient is comfortable with you, with the medicine. And then I can see this is very upset. I am here with you. Don't worry, I am here with you. Give a confidence. In Ayurveda, I have told you in the earlier talk, there are 3 methods. Deva Vyapashra, spiritual healing. Sattva Vaja, psychological counseling. And third is the Yukti Vyapashra, treatment and lifestyle, everything. So I can see this very upset. I am here with you. Let us talk about what we can do moving forward, offer a plan and reassure ongoing support. So basic evaluation tools, what are the tools which a caregiver applies? This ESAS, Admon Symptom Assessment System, this Konfosky Performance Scale, PPS, Palliative Performance Scale, SPICT, Supportive and Palliative Care Indicator Tools, NRS, Numeric Rating Scale, GAD 7, PHQ 9, Mini Mental State Examination, MMSE, and GOCG, Goals of Care Conversation. These are the tools which is available on internet. If you want, you can go in detail, or if time allows, we can take a separate class for all this. They all have a questionnaire, validated questionnaire approved by WHO and different organizations, medical organizations, and you have to apply. What happens? ESAS assess the symptom and intensity of pain, fatigue, nausea. These are the symptoms the patient feels. This assess the scale to guide the symptom management, and this scale measures the functional status of the patient, helps in prognosis and care planning. And PPS assess ambulation, activity level, intake and consciousness. And SPICT identifies patients who may benefit from palliative care. All patients cannot be benefited, but you have to assess it by these are the tools. Quick pain and symptom severity assessment. This is the pain and severity assessment scale, NRS, okay? And this is the anxiety and depression scale. GAD is anxiety and PHQ-7 is the depression scale. And screening of the cognitive function, his memory, that is very, in Alzheimer's, there is a cognitive loss. So that kind of thing you have to assess what is the patient. And lastly, the patient's values, preferences and care priorities. So all these tools are applied for understanding the true status of the patient. Now, the ESAS, what are the questions you ask? Pain. How would you rate your pain right now? Fatigue. How tired have you felt today? Shortness of breath. How much difficulty have you had breathing today? Nausea. Have you felt nausea today? Depression. Have you been feeling down or depressed today? Anxiety. Have you felt anxious or worried today about your disease, about your future or anything? Drowsiness. Have you been feeling sleepy or drowsy today? Appetite. How is your hunger? Have you eaten something? How much you have eaten? All these questions. And then well-being. How would you rate your overall well-being today? I mean, there is a scale from 0 to 10. Depending on this, ask him. It is a self-scoring scale. He will tell, okay, most severe, then 10. No, I'm okay, no symptom, then 0. We will not fill this scale. The patient will fill the scale by himself between 0 to 10. And then the next question, the functional assessment, Karnofsky scale. This is the 100 to 0. What is the 100? Normal, no complaints. Normal activity with effort, some signs and symptoms. 80%. 60 needs occasional assistance but care for most of his needs. 60. Disabled needs special care and assistance every time. 40. Very sick, hospital care needed, bedridden like. 20. This is the last. So from 20 to 100 you have to score because patient is there. So active, example, active, no evidence of disease, this is the 100. Mild fatigue, conditions routine, this is 80. Help with shopping, laundry, this is 60. Cannot stay alone, requires a caregiver, this is 40. And bedridden, bedbound, this is the 20. Depending on the status, you will know the patient status. Then last is the ECOG, performance status, developed by Eastern Cooperative Oncology Group, ECOG, to assess how patient disease is affecting their daily living ability. Though it was developed for the cancer by the cancer treating physicians, but it is applicable to most of the patients in any chronic disease. So this is from grading from 0 to 5. 0 means fully active, able to carry on all pre-disease activities without restriction. 1 means restricted in physically strenuous activity, but ambulatory and able to carry out light work, light house work, housekeeping, office work. Number 2, ambulatory and capable of all self-care, but unable to carry out any work activity up and about more than 50% of the waking hours. This is 2. 3 means capable of only limited self-care, confined to bed or chair more than 50% of the time for waking hours. And 4 means completely disabled, cannot carry on any self-care, totally confined to bed or chair. So these are the 4 stages we have to. When to use ECOG in cancer patient, heart failure, COPD, CKD, frailty syndrome to guide treatment intensity. Palliative care patients to assess decline or when to shift goal to the care. Okay. With these understanding, I have now explained what are the tools which should be applied for the patient to understand the patient condition, number 1, and then to decide the line of services which you will be giving along with the main line of treatment. Now I am going to talk, since because I have taken example of a heart patient, so you must know about the heart and heart disease. So what is this? Understanding the heart failure. This is the heart, you know. There it has the 4 chamber, right ventricle, right auricle, left ventricle. This is the left auricle. This is the pure oxygenated blood. This is the impure blood which needs to be oxygenation. So this is a vein, vena cava. The whole blood carries from the body to vein, to the inferior vena cava and all these things to the left, right one. Then it goes to the left and it goes to the lung. It goes to the lung. This is the lung. Lung gives the oxygen, and after the cleaning, it again comes to the heart. So artery, this goes with the artery to the whole body, and this comes to the vein from the whole body. So this is the unoxygenated blood, this is the oxygenated blood. So 4 chambers, okay. So it is a chronic condition. Heart failure, what is heart failure? It is a chronic condition in which the heart cannot pump enough blood to the body. What are the key points? It does not mean that heart has stopped functioning. It is working, but weakly working. It can affect the left side, or the heart attack, heart disease can be left side or right side or both sides. The common causes: coronary artery disease, I will come to the next slide, high blood pressure, previous heart attack, diabetes and cardiomyopathy. These are the common causes for heart disease. And symptom to watch: shortness of breath, dyspnea, fatigue and weakness while working, swelling in legs, ankles and abdomen, edema, and rapid or irregular heartbeat. You know, for the heart, another resource person, Dr. Suresh Tripathi, will take in detail. I am just introducing you the concept. So what is in the previous slide I have told you the 5 factors, and coronary artery disease I am going to talk in detail. What is the coronary artery disease? There are coronary artery which supplies blood to the heart itself. The whole heart supplies blood through aorta to the whole body, but coronary artery supplies blood to the heart muscle itself. What happens, you see, healthy artery means the blood flow is good. Slowly it starts lipid deposition, you see, fat is being deposited, and then it increases more. So the more fat means low blood supply to the muscle of the heart. Low blood supply means low nutrition to the heart. Low nutrition means weak muscle. Weak muscle means low contracting power. This is the whole process. If heart muscle is not strong, you will get the heart failure. And ultimately you see near complete blockage. In that case, we say the angioplasty is required, and this is assessed by angiography. Another lecture will be there. If you are having this kind of stage, you are likely to get heart attack. sudden heart attack. So patients with chronic heart failure or post myocardial infarction have persistent symptoms and deteriorated quality of life. These people need palliative care. So type of heart failure, there is a left side heart failure, right side heart failure, left ventricular failure, and the connections between right and left heart function. The right ventricular pump blood to the lung, which then goes to the left ventricle. Failure of one side can affect the other, especially if the patient has pre-existing heart disease. So these are the type of heart failure, and diagnostic tools: electrocardiogram, electrocardiogram, ECG, chest X-ray, blood test, and MRI or stress test. These are the common tests which a cardiologist will recommend, and he will analyze. Impact on the health: reduce quality of life. If you have a heart problem, reduce quality of life. Increase hospitalization risk. Needs long-term management, medication, lifestyle change, and sometimes devices or surgical intervention also. The symptoms of heart attack, acute versus chronic. Since we are a palliative care, so we are focusing on the chronic symptoms. Recurrent chest discomfort, this is called angina, gradual breathlessness with activity or laying down, mild sweating with light activity even, intermittent discomfort in these areas, all these are arm, jaw, neck and back, intermittent discomfort, occasional nausea and reduced appetite, persistent fatigue, ongoing dizziness, fluctuating heart rhythm, and ongoing anxiety. These symptoms, if persist after the heart failure, then we have to decide for the palliative care. The key symptoms of the late stage heart, I have told you earlier slide, I am not going to take. When palliative care is beneficial, symptoms are persistent despite optimal medical treatment. Quality of life is poor. Prognosis is limited, means the treatment is not effective on the patient care, and psychological or spiritual distress is present in the patient. So what is palliative care? The goal I have already discussed. Palliative care is specialized medical care for people living with serious illness. It focuses on relieving symptoms, pain and stress, regardless of diagnosis or stage of the disease. The goal of palliative care, as we have already discussed, enhance the quality of life for patient and families, provides relief from pain and distressing symptoms, offer emotional, psychological and spiritual support, and supports shared decision making and patient-centered care. It is the patient-centric care, and coordinated with other treatments like chemotherapy or dialysis. Philosophical goals: whole person approach, care for body, mind and spirit. Patients and family-centered, respect values, culture and choices. Promote dignity, comfort and autonomy of the patient, and provide by a team. Palliative care is provided by a team. It is not a one-man job. A team of doctors, nurses, social workers and family members. So activity assignment on case basis. This is the assignment I am giving to all the students. A patient history and a reaction of family members. Mr. Sharma, 78-year-old, having a heart failure, complaint he has a fatigue, loss of appetite, swelling and trouble in sleeping, and lives with his wife, does not want to be hospitalized again. This is one case. You have to, I have told you the tools, you have to apply these tools and make a report. Case 2, 78-year-old heart failure patient with fatigue, dyspnea and anxiety, lives with his daughter who insists on aggressive treatment. So there are two cases. So what you have to do, interact with the patients and make a decision how to provide a palliative care. Guideline, we will give you a Google sheet in the next slide, and then you have, keeping all these things in mind, you have to fill the questionnaire, and then you will decide what goal you have to do. Which tool would you use, like ESAS, Spike and ECOG, all the tools you apply on these patients and do it. And how would you address the patient desire In first case, with daughter, concern, and second case, separate response, highlighting the empathy. So the take-home message is the palliative care begins with listening. Every word tells a story. You have to listen properly, and then you have to decide. So all the things which I have told you, you have to apply in these two activities, and then you will submit. We will evaluate whether you have understood it or not. So thank you very much.